Hello, everybody. We're going to go ahead and get started. I want to welcome you to the 12th meeting of the CSG National Long-Term Care Workforce Network. I'm Sean Slinham, a senior policy analyst at the Council of State Governments National Headquarters here in Lexington, Kentucky. So here's our agenda for today's meeting. I'll have an introduction and a brief project recap. We're going to get a quick preview of an event happening next month in Pennsylvania, and then we will turn to our main topic for today. We're going to hear about several recent initiatives from our friends at Advancing States. Deputy Executive Director Camille Dobson will join us, along with Senior Director of Strategic Initiatives April Young. They are going to tell us about lessons learned from the investments that states made in home and community-based services, including a number of workforce-focused initiatives with funding from the American Rescue Plan Act. We'll also hear about a companion report looking at the sustainability of those investments. And April is going to talk about the intensive state technical assistance that Advancing States and its partners will provide to 6 states as part of the Direct Care Workforce Strategy Center, something we've heard a bit about on previous webinars. Later on, Camille and April will take your questions, and we encourage our attendees to make use of the Q&A and the chat functions here in Zoom. And we encourage our guests to take a peek in there when you're not speaking and respond to any inquiries if you can. But keep in mind that some of those questions, the entire group might also benefit from hearing the answers to. Before we adjourn today, I will tell you about our plans for our next network webinar next month and other upcoming activities. Just a quick project recap of how we got here. In 2022, with the support of the Commonwealth Fund, CSG created an 8-state task force that guided us in the development of our long-term care policy guide, published early last year. One of the 3 focus areas we had for that project, which corresponds to one of the chapters in the guide, was revitalizing the direct care workforce and supporting family caregivers. Last year, again, with the support of the Commonwealth Fund, we spun off that workforce focus into a project of its own. We've expanded that 8-state task force now into a national network of state policymakers and stakeholder groups. We have a website, our National Online Resource Center, which uses that section of the policy guide I mentioned to highlight numerous examples of state policies going on around the country. And we have been offering technical assistance to states that are interested in exploring ways to address long-term care workforce needs. For us, technical assistance has meant sharing examples of initiatives related to our state strategies to revitalize the long-term care workforce, which you see listed here, and which you'll find a page for each on our website. On previous webinars, I told you about speaking to the Illinois House Human Services Committee in February as that state ponders what's next after passing nursing home rate reform legislation in 2022. I was also in Honolulu in February and got to be part of a long-term care summit there as policymakers kicked off an effort to push through key legislation. And those of you who were able to join us for our webinar last month heard about the legislative accomplishments that policymakers in the Aloha State were able to achieve during the 2024 session. Next month, CSG will participate in what is for us a bit of a different kind of technical assistance event. Our friend Dr. Dan Heimowitz, who is a geriatrician in Levittown, Pennsylvania, is the catalyst behind an upcoming meeting to highlight long-term care workforce concerns in Bucks County that he and others hope can raise up those concerns to a wider audience in the Keystone State. And as you'll see, several of our state strategies for revitalization and a few familiar faces are sprinkled across their agenda for that meeting. Dan, I believe, is joining us today to give us a preview. Dan, are you with us? Can you hear me?
Can you hear me?
Yes.
Hi, Sean. Can you hear me? Great. So I'm sorry, I don't why I'm having technical difficulties. Do you want me to go through my slides real quick?
Sure, absolutely.
Okay. So I can't see them, so
Okay.
I'm going to assume we're up with what?
Yes.
So, this is through the Bucks County Health Improvement Partnership, which is a partnership for like decades that the 6 area hospital have. That's called BCHIP. So we had a similar long-term care partnership, and maybe you guys can help me. I have no idea how to pronounce that acronym. BICLICSIP? I don't know if that's right, Sean. we should talk about that offline. But the concept of this is that we're going to have a state level quality meeting on a county level. Next slide, please. So these are the objectives, and you can read, but I'll summarize. What we're trying to do it as a primary goal is to have this specific to the 31 nursing facilities in Bucks County, but you can look at resources initiatives that are done on both state and national levels. We took the CSG strategies for revitalizing the long-term care workforce and tried to pull out of those things that we thought would be as practical as possible. Where can you get ideas that you can actually use, go home to your facility and use the next day? My suspicion is that there are people that are doing great things that don't necessarily know other people who are doing great things, and people in the long-term care community may not know that. So I think there's a lot of opportunities, and of course there's always opportunities for advocacy. Next slide, please. So this is a busy slide, which I'm not going to read. You'll notice that if you look through this, and Sean, I'm assuming these slides will be available to folks if they want. Yes. You'll have recognized some of these speakers if you've attended many of these meetings. But we've gotten a bunch of great people. I'm going to highlight, and we'll talk about this later, the breakout groups. So we have a lot of fabulous speakers. Now, next slide, please, the when, where. You'll notice the timing of the meeting, if you go back, is that we have a bunch of people talking. They only have like from 5 to 15 minutes to speak. So what we're trying to do is really focus this on what's this initiative that you have, and how can we pull something out of it that you may not know about, and maybe it's good at a local area, maybe it's good statewide. But I do have to give props to Hawaii. I have to say Sean has probably had a better visit to Hawaii. We're going to try to make it good for you here in Bucks County, Sean. But go on to the next slide, which is the flyer. Sean, yep. Is that right? What we did is we just brazenly stole the title from Hawaii's talk for meeting. They called it Meeting for Champions. My masters liked that, so we just stole it. So I hope that's, I'm just thanking my friends from Hawaii. So note the date. It's June 21st, 2024. It's the registration date 15. The meeting itself is 9 to 12. So if you can register with Colleen, her email is there, ccampbell@beachip.org. And if you register, say you want to come there, and you'll get the information for the hybrid part after you register. So finally, the expectations input. It seems to me the information one is going to get from this is applicable, if we do it right, on a county, state, and national level. So for those of you who live in counties, states, or in this nation, hopefully there'll be a good deal of this that will be applicable and useful to you if we do it right. Now, a lot of this stuff is based on the CNAs. A lot of talk has been this way, but there is going to be things in here about expanding the pipeline that go beyond that. Like I'm doing a little project with college students. A friend of mine is, Jay Slotkin, is working in New York for high school students, which doesn't necessarily mean it's just going to be for CNAs. If you have any questions, I thought that I'd be on this call that you could put in the chat, but if you have questions, get it to Sean, he'll get it to me, or you can email me. I found out the IT capacity. We can handle 200 to 250 people at this point. And we're going to have breakout sessions. And again, hopefully we'll have the IT capacity. The breakout sessions are going to be the key things here. This is an introduction. I know these meetings are different from the two that CSG had previously, but the idea of the breakout sessions are, what can we do? What is needed? What's the next step? Who's going to take on the mantle of leadership here with connecting thing in Pennsylvania? And I'm hoping that we'll get CSG follow-up. And the ultimate goal, which is similar to that asked of CSG, is the development of state action plan. That's what I got. I hope that was succinct enough, Sean. If there are any questions in the chat, or anybody has questions, happy to answer.
Yeah, as you said, the folks can get in touch with me, or they can email you at your email address there, or get in touch with Colleen if folks are interested in attending virtually. Dan, thank you so much, and I look forward to
Sean,
attending.
I got that right. I got that right, didn't I? That was your impression of the meeting too, right?
Yes, absolutely.
Okay.
Yeah.
Okay, good. All right.
Th
Thank you.
Thanks so much, Dan. And again, I look forward to presenting and seeing what comes next from this meeting in Newtown next month. Now, without further ado, we want to dive into our main topic for today, which is some recent reports and activities involving our friends at Advancing States, the organization that represents the nation's 56 state and territorial agencies on aging and disabilities and long-term services and supports directors. They have recently released reports on lessons learned from state implementation of ARPA HCBS spending plans and approaches to building on those investments to ensure the future sustainability of home and community-based services. Advancing States is also one of the partners in the Direct Care Workforce Strategies Center, which is providing technical assistance to states on how to build capacity and drive systems change in the direct care workforce. And we will hear about all three of those initiatives from our guests today. Camille Dobson is Deputy Executive Director at Advancing States, and April Young is Senior Director of Strategic Initiatives. Welcome to you both, and please take it away.
Thanks, Sean. Appreciate that. Next slide. Those are our pictures, but you can see us now on the screen. We are senior leaders here at Advancing States. I drive our Medicaid policy work, and April, notwithstanding her amorphous title, is driving all of our direct care workforce work. So happy to be here today to talk to you a little bit about the work that we've been doing to support our members. Next slide. So we're going to cover these three things that Sean already talked about. I have a lot of slides. I'm not going to cover a lot of detail on all of them since I know Sean will send them out, but I always like slides as a resource. So there are a lot of words. So you can look at them at your leisure after the session. Next slide. Next slide. So just a very brief background on the American Rescue Plan Act, Section 9817, enacted in the midst of the pandemic, provided a boost to states' home and community-based services programs by providing additional federal funds for expenditures that states were already making in their HCBS program, and they needed to use those funds to reinvest in the HCBS system. Next slide. So it has turned, while it was estimated when the bill was passed that it would generate about $25 billion in new state and federal spending, it actually has turned out to have generated $37 billion in new spending. And states had two things. They needed to, could not substitute the new federal funds for what they had already been spending. And they needed to be, the additional federal funds that they realized need to be spent within a specified time period, was originally 3 years, has now been extended to next March of 2025. We actually have, I think, 3 states that have asked CMS for extensions beyond that date later into 2025. Next slide. So this is just a high level. I stole this from CMS. This is not creative. You would find this on the CMS website, but it provided a really nice snapshot, a map of sort of where the spending happened. You can see that it's, the darker states are those that have typically more expansive Medicaid programs, New York, California, et cetera, and Mid-Atlantic typically. But also shows, I thought was interesting, about $5,000 additional spending resulted per beneficiary across the country that are getting HCBS. Next slide. And I pulled this specifically because the number one, and I'm sure this is not news to you, the number one investment across the states was for workforce recruitment and retention, because we all recognize that without a direct care workforce to provide the hands-on care that people need to get out of bed, to eat, to bathe, to dress, there is no living at home for folks. And so I thought it was interesting. Every state invested at least some of their ARPA funds in workforce workforce recruitment and retention. And actually, of the 37 billion, about 25 of it. So that's, I don't know, I don't do math well, but I think it's about 3/4 invested in just this slice of the work. So if you are at all interested, this graphic is on CMS's website. You just go to medicaid.gov and put in 9817 at the top, and this graphic will pop up, and it covers 5 or 6 different elements of states' ARPA spending. Next slide. So we were lucky enough at Advancing States to get funding from a collection of foundations that felt that support for states was really needed to maximize the benefit and the impact of the ARPA HCBS investments. One of the tasks that we proposed was sort of an evaluation report. It's not really an evaluation, but an assessment of how states actually found working through the ARPA process. I know it's pretty boring, but the reality is that without a sort of streamlined and effective engagement with both their state legislators and the federal government, states are really hampered in moving these initiatives forward. So we decided, since these are our members who implemented the spending plans, did a survey to understand how the states approached it, and then what recommendations we could give to federal policymakers and state policymakers if there should ever come to be an opportunity like this again. The Biden administration has talked about this ARPA spending being a down payment for the real investment in HCBS. And so we already know that Senator Casey has filed a bill to extend that additional 10% federal match rate for another 2 years. And there are lots of, I think, learnings about short-term investment. Sure. So we fielded a survey to our states. We got about 65% back, which I think is great given the fact that the states are all in the midst of unwinding from the public health emergency. And we published a report. The link is in this slide. And I will, before, when April's talking, I'll put in the link to the 9817 graphic. So next slide. The states had to put in a spending plan within 8 weeks of the legislation being passed. That did not leave any time or very little time for stakeholder engagement, left virtually no time to engage with state legislators. And so they turned out to be very much a wish list of all the things that a state might want to do that they maybe have been percolating about for the last, however many years, if an opportunity provided itself to improve their HCBS system. And what we found is that about of the states that reported, they've only actually implemented about half of what they proposed by, almost 3/4 of the way through the spending period. And a little over half of the states actually said that they terminated about 25% of the projects that they started. In other words, they had a great idea. For a number of reasons, those never came to fruition. The state has just stopped working on them. The remaining projects are somewhere in the process of being implemented. Next slide. So you're not going to be surprised to find the four sort of major hurdles that states had to overcome in actually effectively spending all of the money. The first was at the federal level. CMS was not prepared for the onslaught of work that was coming, not just to approve the spending plans, but also to get approval to approve the underlying HCBS changes that need to be made in the program. Staff capacity, most states, the vast majority of states didn't get any additional assistance. They got no administrative funds from ARPA. And so they were already taxed in the middle of the pandemic with shouldering a huge new initiative with no additional staff. They were hampered by the amount of time it takes to actually contract for assistance, if they could do that, or to procure technology. And I'm sure I don't need to tell you how long that can take in state government. And then last but not least, were more than a handful of states who actually were prohibited by their legislators from spending any, they generally are not allowed to spend any federal funds at all before they've been either approved or appropriated. And then another handful of states actually imposed new requirements for approval before any of the funds were spent. We had one state, will not be named, actually didn't start spending money until a year ago. And so they basically sat for almost 2 years on those funds because they didn't have legislative approval. And then of those barriers, the vast majority of states indicated that the lack of staff capacity was the culprit. And they really could not manage the additional work on top of what they've been doing. Next slide. So we asked states, were they actually going to get all the money spent? Because that's actually helpful again in thinking about future federal policy and, advice to Congress. And we have a handful of states, about a quarter of the ones reported, spent their money quickly because they were able to get out from under some requirements about not being able to change their HCBS programs while they were spending the federal money. So they made the decision to make short-term investments and be done with the spending. About 60% will be finished by the deadline next March, and then about 20% have either asked for or intend to seek an extension beyond next March. And we know, as I said, 3 states have already received approval. Those are on a case-by-case basis with negotiation from CMS. Next slide. So we recommended 4 big things, and these are not going to be surprising based on the barriers that we talked about. States need more time to be able to put together a thoughtful plan. There was, consultation. We had a lot of feedback from stakeholder groups, providers, consumer advocates about the lack of input they had into the state spending plans. And you can see that sort of playing out by the low, sort of the 0.5% of initiatives that were actually implemented. The legislation, surprisingly, federal legislation did not take into account states' legislative and budget cycles. And so the money was released after the vast majority of state legislative sessions were finished for those that don't have year-round sessions. And so they had to wait till the following session potentially to get approval. So they're already 9 months behind. CMS and the states really need to get on the same page about how they're actually going to process the administrative work that needs to get done. For these, and both the states and CMS need administrative funds. They cannot manage this kind of implementation work without additional resources. Next slide. So we're very hopeful that report was released. We've done a summary that we're made available to our federal partners and those folks that are thinking about additional investments. And we're hopeful that the next time around, there'll be an opportunity for more thoughtful implementation timeframes and resources. One of the other activities that we were funded to do was, again, back to the ARPA as a down payment for HCBS was, and it was time limited, as you know. What does that mean about the long-term sustainability of our HCBS system? And so we hosted a summit with a lot of really good thinkers last October to think about really sort of big picture, out of the box recommendations that are strategies that the group could make both to Congress, to CMS, to their own state agencies. I'll show you a little bit of what that looks like. Next slide. This is a list of the folks that were included in the summit. We had 10 state leaders and 10 non-state leaders from really important advocacy organizations, or those, for example, PHI, that are knee-deep in workforce work, AARP that puts out the LTSS scorecard, Community Catalyst, for example, that supports consumer engagement in HCBS. Next slide. So we've talked a little bit of the summit report that was published, really provides a pretty discrete individual activities or strategies that could take place based on who the actor is that's driving that policy. But it also talks very big picture about the HCBS system writ large and how it fits into our larger healthcare system in the United States. And the report, I can't stress this enough, that both the states and CMS need additional new resources to implement any of the strategies that are in there. The states, I don't need to tell you probably, that state staff is retiring at a rapid rate. And HCBS is one of those areas that it's very hard to get brand new staff into and understand those complexities quickly. So Medicaid is complicated enough, and HCBS is its own sweet little, tunnel that people live in that's much, much more complicated than even general Medicaid policy. Next slide. So these are the principles essentially that the group came out with. And I think, I'm not going to read through these, but I think one key factor is that the system recognized that people's preferences are to live at home. Very, very few adults will say, yes, I'd like to live my last days in a nursing facility. They prefer to age at home. Our system is not constructed that way today. One of the principles is that there are huge equity implications in our current HCBS system about how people find out about services, access services, the types of services they get. And so looking at the system with a lens towards addressing those disparities. And having the voice of the consumer who receives services at the center of the policymaking process. Next slide. I'm flying through these, Sean. This is a snapshot of the 5 categories of strategies that the report covers. There's much detail about each of those, very specific. I'll show you on the next page specific strategies with accountable entities sort of assigned to them, but you'll see the ones closest to the house are the ones that are most doable, or the ones that are the highest priority. So you will see right off the bat, expanding the HCBS workforce and support family caregivers, the number one opportunity, the number one pressure point, the number one imperative for sustaining our HCBS system, as I said. Secondly, technical assistance and information sharing. I don't know about you, but we find from our members that they are focused on their own state. They are buried in the work that they're doing in their own state. They rarely get an opportunity to look up and around the country, so that they are not reinventing the wheel. There's not enough technical assistance coming from CMS, so we made some recommendations there. And a broad dissemination of promising practices. So even without technical assistance, states could pick something up and replicate it from another state. The third is federal and state administrative capacity. I've beat that horse already twice, so I won't go on to that again. But clearly, CMS is understaffed. And even without ARPA, they do not have enough staff to manage what is a very, very large and growing portfolio of their Medicaid programs. Information, referral, enrollment, eligibility assessments is really the front door. So all kinds of opportunities to improve the way people understand the access to HCBS. Hospitals, for example, don't mention the services that are available for people to go straight home instead of stopping by a nursing facility. People wait until there's a crisis before they call and say, hey, my mom had a fall and can't come home. Now what do I do? There's a whole bunch of improvements that can be made on that front door piece to our HCBS system. And then last but not least, furthest away, because those typically require congressional action, are new funding opportunities and payment reforms for HCBS. Primary among that is making HCBS the preferred alternative and nursing facility services optional. And so that the imperative is community first. Right now, hopefully you know that nursing facility services are required, mandatory Medicaid benefit, home and community-based services are optional. So states have to offer every single person the ability to go into a nursing home, whether that's right or not. And it is the path right now of least resistance. And we'd really like to swap that imperative. Next slide. And I think this next one is just a snapshot of what the strategies look like in the report. So I picked up, for example, this issue about an entitlement for HCBS. Obviously, that requires a statutory change to the Social Security Act. That would be Congress's role. But we talk a little bit about why we've made that recommendation and have cautioned Congress that adding both as a mandatory benefit will just explode the Medicaid program, which we can't do. So needing some specific levers to allow states to manage access to more expensive facility-based services is really important if this switch were made. I think, am I right, Sean? That's it for me. Am I right?
Yes. Yes.
So I guess we'll wait until the end. You will take questions if anybody has it. In the meantime, I will put the link for that CMS report in the chat.
Sounds good. Thanks, Camille. I just thought I'd round out today's presentation talking about some different ways that Advancing States is supporting states to improve the direct care workforce and the workforce crisis. You can go ahead and go to the next slide. And mainly wanted to focus on one of our efforts through the Direct Care Workforce Strategy Center. And I've got the website up here on the slide. Please go check it out if you haven't already. They have done a lot of work to culminate some resources, some data and research about the direct care workforce. Under that events link, you can see some different opportunities to attend webinars. They actually just had one today about the HCBS data infrastructure, and Sean presented on that webinar. So they're really good about posting the presentation and the recording and the slides. So you can see that later if you want to check that out. And then under technical assistance, you can learn more about the intensive technical assistance that I'll talk about today, as well as the peer learning collaboratives, which is a separate group of states. I think there are 14 states, yeah. 14 that are involved in the technical assistance opportunity. And so if you want to learn more about that, you can find out there. I think that was it for this slide. You can go ahead and go to the next one. So Advancing States is hoping to spearhead the intensive technical assistance. We have a lot of partners in this work, obviously NCOA with the Direct Care Workforce Strategy Center on behalf of ACL. NASD's and NAMBY, so the Developmental Directors Association and the Medicaid Directors Association are also helping us run the intensive TA. And then I also wanted to call out PHI and the University of Minnesota, who are subject matter experts and are really going to be able to help states with some of the data questions that they've had and speaking from their expertise and their perspective as well. So there are a lot of different players in the intensive TA. Also wanted to talk about what all states receive in this opportunity. So you just heard Camille talk about, I just wrote it down, 83% of states shared that if they didn't finish an ARPA project, that it was due to lack of staff. And so we wanted to be able to provide states as much assistance as possible with completing some of the workforce projects that they want to complete. And I'll talk about that in a little bit. But we were going to do that by supplying them with a technical assistance coach. We have paired each state that was selected with a coach. They'll receive 250 hours of technical assistance between the coach and the SMEs and an in-person visit by the coach. Access to the subject matter experts like PHI and UMN. There's many more that are involved, but wanted to call those two out. And then opportunity for peer-to-peer learning and exchange. You also just heard Camille talk about states that are not able, just so busy, not able to reach out and see what other states are doing. So that was an important part of this opportunity as well, is to get the states together. There were 6 that were selected and allow them to see what's working, what's not working. There were some themes that we noticed across all 6 states and what they wanted to accomplish. So being able to learn from one another is going to be another kind of unique aspect of this project. And we just kicked off yesterday, so this presentation is really apropos. Got to hear a little bit from each state that was selected. They had 5 to 6 minutes each, so it was kind of cool to be able to kind of see the themes that came out from all of the states that talked. And then the other thing I wanted to share was that this opportunity is really focused on systems change and change across agencies. So not just from the Medicaid agency or maybe the where LTSS occurs within the state, but also bringing in Department of Labor, workforce departments, and also Department of Education maybe. So really trying to come at it from that perspective, and I wanted to emphasize that as well. Next slide, please. So the technical assistance runs through December 31st, and there's an option for states to extend through the end of February if there's some closing activities that states want to work on. These were the states that were selected. So we had 11 states apply to the technical assistance opportunity. We interviewed every single one and then selected the 6 that you see here. We were trying to go for a good geographical range based on who applied. There actually wasn't a state from the southeast region of the country that applied. So I thought if we get to do this again, we should do a better job of reaching out to them. And also wanted to get a good diverse group of states in terms of where they are in their workforce initiatives. Some states are kind of just starting and really want a good plan across the agencies for bolstering the workforce, supporting the workforce. And then some states already have a workforce plan and have been working on the plan and accomplishing some of their goals already. So we wanted a good selection from that perspective as well. Some of the key themes we heard yesterday across the states were around the benefits cliff for direct service workers and figuring out solutions for workers who maybe take a promotion or start earning just a little bit more money and then lose their benefits, but aren't making enough money to make up for the benefits that they lost. So a way to address that issue that came up a couple times. The access rule and bringing in, thinking about the requirements in the access rule and how that could be addressed in the technical assistance plans as well, and kind of factoring that in. We heard about non-monetary support for direct service workers, and instead of just focusing on wage increases or maybe bonuses, but other ways to support workers, if that's setting up a call line or a like a mentorship program or something like that. We also heard a lot of states mention the need for data, and that's probably something you are aware of as well. Just in this area, there's not a whole lot of great workforce data for states to use for decision-making and for planning. And then in terms of specific projects that we heard about, one state talked about program evaluation and trying to determine if the funds that were spent on some of the ARPA projects that we heard Camille talk about, did those have the intended effect? Did they have the right impact? If they replicated some of those programs again, would it still, would it have the intended effect? So kind of determining effectiveness of programs and evaluating results. We also had another state talk about a peer mentorship program for direct service workers and how to set that up statewide, figuring out the action plan for that. We had a couple states talk about their partnerships with the Department of Labor and working with them to provide training for direct service workers. We had states talk about developing career advancement programs, career development initiatives, and collaboration with higher education. So a really broad array of projects that states want to focus on. It was an inspiring meeting, I'm not going to lie. Just hearing about from the states themselves what all they wanted to work on. And then we also, part of this opportunity is, and requirement is for states to set up a direct service workforce advisory board. And we will be helping states with that. We can provide templates. And we just really want to stress to the states that it's not, and I understand this, but we don't want a state to take an already existing group and add maybe 1 or 2 workers to that group and call it a direct service workforce advisory board. We really want a group that is mainly comprised of people doing the work in the field and comprised of direct service workers. So we will also be working on that with our states and talking with them about how to set those up. Next slide, please. And then I just wanted to shout out to the 2024 HCBS conference. The registration is open. I think it just opened last week. So please, if you're planning on attending, the link is there on the screen. And also wanted to call out the last day of the conference will be the Caregiving and Direct Care Workforce Intensive. So it'll be a day-long intensive of, cram-packed with workforce and caregiving experts, and also of the intensive TA states. So they will be there as well, talking about their experience, among others. So we hope to see you there. And I think that rounds out my slides.
I just wanted to throw in really quickly, April's very modest, but she has been supporting a direct service worker advisory board in Indiana, and is supporting Missouri as they set up a new one. So we have a lot of direct experience in helping states think through how the nuances of bringing workers together to hear their perspectives. So didn't want to let that go unmentioned.
Okay, thanks, Camille. Yeah, it's been cool to see states kind of across the country start to pick that up and implement that within their state. I think anytime you can hear directly from people out there doing the work, that's probably a good thing. So thanks for bringing that up.
Great. Well, April and Camille, thank you both so much. And we want to turn now to questions, and you can type a question into the Q&A box or the chat box, and we'll answer as many of those as time allows. I know we had a question earlier from our friend Shirley Gerard asking about the role of GWEPs, those geriatric workforce enhancement programs. Would either of you care to comment on the role that those can play?
Well, I can't because I've never heard that acronym before. So I'm out. I don't know if April knows.
I Googled it while you were presenting, so I had never heard of that either. But it looks like loans about the geriatric workforce, but not for states, maybe for like more schools, assistant education programs.
Yeah.
I don't know. So maybe on a different plane. Looks like those grants are on a different level, maybe.
Although any work to supplement, direct care workers aren't in HRSA's shortage of health professionals because they're not considered a profession. And so I think that's an opportunity that a number of entities have talked to the HHS secretary about, is adding direct service workers as an underserved, under-resourced profession. That makes them eligible for all kinds of loans and preferential tuition and stuff like that. So definitely a gap.
Shirley Gerard, are you with us? Can you did you want to say a word or two about she may have left us. Say a word or two about GWEPs.
I'm here. I'd love to. I was just putting something in the chat. Okay. The geriatric workforce enhancement programs are, as you say, to universities or other places that provide education, but they really are intended to link with national programs, including some of the apprenticeship programs. It does include, has in the past, there was a supplement for long-term care, which focused on CNAs particularly, and articulation, and a pipeline for them in terms of becoming workers. So the professional piece of it is somewhat misleading, I think. But I think there's great opportunities to collaborate and build some synergy around this. The new geriatric workforce enhancement, their cooperative agreements are have a very big emphasis on long-term care, and a lot of innovation in nursing homes related to what we've applied. And my other life is with SUNY Downstate, and looking at primary care in long-term care facilities, looking at how we can enhance the workforce and recognize the workforce at every level and move people through the ranks. So I think it's a great opportunity to collaborate, both at the federal level and at the state and local level. So thank you for opportunity to talk. I'd love to talk more about this.
Thank you, Shirley. Thanks for that extra explanation. We appreciate it.
Yeah, thanks so much, Shirley. And we can have time for a few more questions. Camille, one of the things that we had talked about in preparing for this webinar was that, you know, states were kind of in a race to push all of these initiatives and programs into the field and spend the money allotted to them in the limited time frame that they were given. But what was sort of a lost opportunity here was that there were only limited examples of states trying to evaluate how any of these programs actually worked. And I know it's sort of beyond the scope of the survey data that you all collected for this project, but is there anything that we can glean about the effectiveness of various strategies based on anecdotal evidence or otherwise? And how can the lack of evaluation efforts inform future policy if there's ever, you know, another massive federal investment in HCBS, if this Casey bill comes to fruition or what have you?
Yes, that's a really that's a good question, Sean. And actually, the third pillar of the work we did with our foundation partners was actually to do a study assessing the effectiveness of states' evaluations. And what we come to find out when we started sent out a survey to states and started talking to them was that very few states had built any. There's the third report that we've put out, the link. Very few states had built any evaluative criteria at all into their policy, into their programs. They were just rushing, right, to get things out. Back to April's point, there's not a good base of data today for states to know how many workers they have in the state, what their average wage was. So there was virtually, it was very, very hard for states to say, well, we gave them an extra $3 an hour. What did that do? Because they don't have a sense of what their environment looks like today. What we did find, one of the states that's been selected for April's, I call it April's, for the intensive technical assistance is Colorado. And they are the shining star across the country. They actually did build a very specific sustainability assessment rather than an evaluation in their ARPA plan. They had 62 initiatives, and they had structured a way to evaluate whether they were successful, should they be continued with state funds, should they be terminated, should they be merged with other funds. And so this report really highlights the work that Colorado has done to this degree so far. Other states had some very specific assessments, which we had to call evaluations of specific initiatives, but nothing as comprehensive as Colorado. One of the recommendations from the Sustainability Summit is that, which I didn't highlight today, is if there should ever be another round of federal investment, that Congress require CMS to do a national evaluation like they have done with so many other grant programs like Money Follows the Person and the Balancing Incentive Program, because the states just don't have the capacity typically to do it.
Great. We had a question in the Q&A about this person asking, wondering if you could say more about where states are spending more on recruitment and retention, in what kinds of settings and among which types of professionals.
Well, the focus of ARPA had to be on home and community-based settings. So notwithstanding Shirley's comment, it was not focused on individuals in nursing homes. It was primarily focused on those individuals, what are called direct care workers, direct support professionals. They have a whole bunch of different names that are serving people either hands-on assistance in their homes, or, for example, for folks with IDD, providing employment supports and those kinds of things, but very hands-on person-to-person work. They are typically not considered professionals in most states. 18, a driver's license and a criminal background check is all that's necessary to become a direct service worker. A number of states do have curriculum and training that's required, but not all states do. There's no federal standard for that, as HCBS is not licensed or overseen or at a federal level like nursing facilities are. But they spent a lot of money on one-time bonuses, retention payments. In other words, because of COVID, there was a lot of fear of individuals going into homes. And so to retain workers so that they could keep serving people, they made one-time retention bonuses. Those were probably the largest. Most of that money went directly to one-time payments to direct care workers. Again, remember, it wasn't permanent. So if states had raised their wages on a permanent level, after 3 years, they'd either have to drop the wages back down again, or they need to look for state support to continue to pay those. And not every state legislature is willing to actually, or governor willing to put money forth to keep those wages up. So it was very one-time, but one-time payment increases for individuals.
Yeah, I would just add.
Go ahead.
Oh, I would just add, I think we are hearing a lot from states about offering support to direct service workers and seeing that translate into retaining workers. If you think about it, going into people's homes and providing these services can be really isolating. So providing like that mentorship program I mentioned earlier, one state is focusing on, and just helping workers, especially new workers entering this profession, not feel like they went through 10 hours of training and here they are. So really providing, looking at ways to provide support. And then we've also heard from states in terms of retention, looking at the high school pipeline or community colleges and trying to intercept younger staff, for lack of a better word, into the profession and just letting them know that this is an option, that it's a great option if you're interested in healthcare, just to get some experience with people. And I'd say that's something we've heard from a few different states as well.
We had another question here in the Q&A. This person asking, does it seem that many states requested funds to cover new staff for the ARPA projects, even on a temporary basis? And if not, would there be an opportunity for them to do so?
The ARPA funds that came from the federal government were only for services rendered. So there was no administrative funds in that federal pot. There are, again, a handful of states, Colorado among them. They were, I think they had enough appropriations from their state legislator to hire 68 staff to support those 62 initiatives. But most states did not get any new staff. They may have been able to use contract funds to help to solicit consultants, folks like us at Advancing States who help states on a contract basis, specifically for projects. But the vast majority of states, if they didn't already have an existing consultant arrangement, basically just made do with the staff that they currently had. So, but that's the problem with additional federal funds coming through the Medicaid funding formula. That's only for services. There needs to be a specific appropriation for administrative funds for states.
As we wrap up here, one of the broader sort of existential questions that comes to mind for me is that, one of the goals of this HCBS investment was to shift the institutional bias from facilities-based care to the HCBS that most Americans say they prefer, as we know. Do we have any sense of how much these investments sort of move the needle in that regard? And, what impact did the overwhelming workforce crisis have in terms of limiting the success of those investments?
Yeah, I mean, I think the overarching goal is always to what we call rebalance, which is a misnomer because there never was balance between institutional and community services. ARPA was really intended to be system building. So, for example, a pipeline of additional direct care workers to serve folks in the community allows individuals, for example, to either leave nursing homes or hopefully bypass nursing homes completely. I think there were 10 or 12 states that actually added HCBS slots to their current HCBS waivers that would allow them to serve more people. A handful of states eliminated waiting lists. So those are all activities that are resulting in more people being served in the community than in an institutional setting. I'll be honest with you, Sean, I think, CMS's expenditure data that shows, total LTSS expenditures in the community and in the institutions is usually about 2 years lagged. So we're expecting, hopefully by the 2025 or 2026 expenditure report, we should see the lagging, sort of the full effect of those investments that came out in 22 and 23. We'll see. I think it remains to be seen. It's a heavy slog in a lot of states. The nursing facility lobby is very, very strong, and the states are really fighting uphill to get more people served in the community.
Yeah. Great. Well, Camille and April, thank you so much again for joining us, and thanks to Dr. Heimowitz as well. We are just about out of time. Before we go, a few quick updates. If you weren't able to join us for our last webinar back on April 30th, the recording of that meeting and slides have now been posted to the resources page of our website, where you will also find materials from all of the other webinars that we've done as part of this project. Last month's meeting was the one where we got an update on the workforce-related initiatives of the Moving Forward Coalition and heard about the legislative successes in Hawaii during the 2024 session. We are looking at June 27th at 3 p.m. Eastern Daylight Time. For our next network meeting, we're going to highlight state and local strategies to support family caregivers. More information to come on that one, and I will send out an email to our mailing list with the link to register once we're able to confirm those details. If you are not on our mailing list, shoot me an email. I'm at sloan@csg.org. Please check out our website, the National Online Resource Center, at web.csg.org/long-term-care. Send us any relevant bills or other resources that we may be missing on there. Next month, as you know, I will be in Pennsylvania for the Bucks County Long-Term Care Summit. If you happen to be passing through Newtown on June 21st, or if you'd like to join virtually, please reach out to Dan or myself. And in August, as you heard April mention, Advancing States is hosting the annual HCBS conference in Baltimore. I will be there. Just book my travel. And so if you see me in the hallway, please stop and say hello. I attended last year, and it's really a great and very informative event that Camille and April and their outstanding team put together every year. And finally, during the last week of August, as we did last year, CSG will be hosting 2 Medicaid Policy Academies back-to-back in DC. Those are for state legislators and executive branch officials, including Medicaid directors. And long-term services and supports are always a focus on the agenda for those events. Happy to provide more information on our academies to anyone who may be interested. Thanks again, everybody, for joining us today. Don't hesitate to reach out with any questions or concerns. For now, I'm Sean Sloan at CSG headquarters in Lexington. So long.